ahead and get us started. Thank you everyone who's in attendance so far. I am Dr. Ruth Nutting, Chair of the Families and Health Special Interest Group, and myself and the team's excited to have Dr. Jerica Burge, Dr. Ali Crandall, and Dr. Nomi Lees-Lexer joining us as our presenters today. So they will be presenting on assessing family level processes, lifestyle, resources, and social capital in primary care settings with the family health scale. So to give some brief bios, Dr. Jerica Burge, who's with us, she is a tenured professor and vice chair for research in the Department of Family Medicine and Community Health at the University of Minnesota Medical School. Her research focuses on risk and protective factors for childhood and adolescent obesity. She has expertise in conducting mixed method studies that include observational methods such as ecological momentary assessment and video recorded tasks, as well as quantitative survey data to more fully understand the complex family dynamics and processes related to physical activity and dietary behaviors in children and adolescents. So she is one of the most cited authors on family dynamics and childhood obesity, with over 150 publications and 300 presentations. Very impressive. Dr. Ali Crandall, she is an associate professor in the Department of Public Health at Brigham Young University. Her research focuses on the effects of family health on adolescent and adult mental well-being. She conducts survey research in community and online samples to better understand how family experiences in childhood lead to adult family health, with the ultimate goal of facilitating a greater family focus in public health practice. Her secondary research interest is that to better understand how cognitive health, such as self-regulation and executive functioning, affect family and individual health behaviors. And then lastly, we have Dr. Nomi Lees-Lexer. She is a NRSA postdoctoral fellow in the Primary Care Research Institute in the Department of Family Medicine at the University of Buffalo. She currently teaches a graduate level course on families and population health in UB School of Public Health and Health Professions. Her research integrates family science, public health, and implementation science perspectives. In addition to her family health measurement research, Dr. Lees-Lexer conducts mixed method studies on perinatal mental health in obstetrics and the pediatric settings among underserved populations. All right, thank you. I'll let you all take it away.
Thank you so much, Ruth, for that introduction. This is very exciting on behalf of my co-authors, presenters, and myself. Thank you for tuning in. I know it's the summertime and we have lots of competing demands, so thanks for being here with us. We had the opportunity to present development of our family health scale at last year's CFHA conference, and this is really a wonderful opportunity to give updates to that work and show you all how it's being used in the field and in research and practice, and talk about some future applications that we're really excited to share with you. And if I can advance my slides, we have no disclosures to report. So we have 3 learning objectives. The first, to describe the importance of assessing family health within primary care settings specifically. I'll be giving some of that overview. Secondly, to demonstrate the development, validation, and screening potential of this scale. Ali will take us through that. And then we'll also be sharing among the 3 of us, different studies and applications of the scale and future work. And lastly, Jerica is going to lead us off in a discussion about future applications of the scale. And we'd really love to hear from all of you. We'll try to reserve at least 15 minutes at the end for a Q&A. So families are critical to health. They're critical to health of individuals, as well as linking individuals to their communities and improving community health. And many of you may be clinicians, either in social work, psychology, family medicine, pediatrics, or clinical researchers. And I imagine you have a profound appreciation for the vital role that families do play in health. For example, a clinician might take a family health history or ask about intimate partner violence in service of linking a family or individual to the appropriate services. Family health shapes life course trajectories over time. and are particularly critical during life transition moments, such as a birth or a death or a marriage, and are very important for children and health development of children, but are not just for kids, right? So really are vitally important to provide context of care and continuity throughout life. So a little bit on our perspective on this topic. We merge fields of family science, which talk about how families work as both a mediator and producer of health, using a systems theory, thinking about families as a system that can either be functioning pretty well or maybe need some future help or assistance in getting that system up and functioning at higher capacity. And then public health, which is what I'm trained in, is looking at population trends over time, how family demographics impact individual health and community health. So for example, single-headed households and blended families, what impact does that have or not have on individual health? And then clinical practice, knowing the right questions to ask and how to make assessments for an individual's family's unique situation and making prognoses. So what we found over the years that is missing in this work is a consistent way of measuring what we mean by family health. So part of this work is to do just that, is to come up with a standard set of concepts and domains, what we think that this means, and then to really be able to measure it, because we can't monitor progress in areas that we're not measuring. We can't ask payers to pay for aspects that we think are important to care without that measurement. So that's really the goal today, is to find a systematic way of measuring family health. So some of the fundamental work in this area was funded by the US Maternal Health Bureau to look at defining family health. And so this work was based on a Delphi expert process. And the definition that those experts came up with is that family health is a resource at the level of the family unit that develops from the intersection of health of each family member, their interactions and capacities, as well as the family's physical, social, emotional, economic, and medical resources. So family health is related to family resilience, it's related to family functioning, and really we think that it predicts that. And now I'm going to pass it on to my colleague, who will describe the development of the family health scale. Ellie?
Thanks, Nomi. So those of you who have been involved in scale development know that it's a long process, and this is sort of a summary of what we went through. So first of all, we looked at that work we had done in that Delphi expert study, and we call that the Measurement Resource Network. And we had come up with sort of these main domains that we felt like fit within that definition of family health. We also found some work that Sharon Denham had done for nurses, and she had done some qualitative interviews in Appalachia and had come up with a family health model. So we kind of combined the work from the MRN and Denham's framework to make sure that we were looking at questions that comprehensively would get at this measure or this aspect of construct of family health. So we first of all looked at existing measures of family functioning, family dynamics, family communication, and a variety of other family skills, because we felt like together we might be able to find a lot of aspects of what made family health. And so we looked at some existing questions and modified them and did some content and base validity to create an initial scale, which we then refined over multiple surveys to national audiences until we came up with a form that was more than 40 questions. We ultimately wanted to get it down to fewer questions than that. Our hope was to have both a long form version that we could look at different subskills or different competencies of family health, and then a short form that could be used for quicker surveys and also as a clinical measure. So we piloted this initial scale that we had found with 1,050 adults and did some item analysis and used structural equation modeling to look at the exploratory and confirmatory factors. This ended up reducing our items down to 32 items for the short form and 32 items for the long form and 10 items for the short form. And I'll go through in the next slides kind of some of the what we found. So with the long form, which is 32 items, we found 4 dimensions or 4 subscales. These were the family social and emotional health processes. So this gets at satisfaction with family life, how well people communicate within the family, how connected they feel with each other. And it has quite a bit of correlation with some measures of family functioning. We also looked at the family's healthy lifestyle. So their support of each other in eating healthy or exercising or following medical recommendations, which was very interesting to consider during COVID. And there's also family health resources. This is an interesting dimension because it includes both material resources like socioeconomic status, income, housing, food, but it also includes more internal resources that the family has. So their ability to balance these work-family conflicts, their help-seeking efficacy, some of their coping aspects would fall under sort of these internal resources. And finally, the family external social supports. This looks a little bit like social capital, but at the family level. So if a family needs outside help, which all families do they know where to turn? Do they have others that they can turn to? Each of the 32 items was assessed on a 5-point Likert scale, ranging from strongly agree to strongly disagree. And we had we reverse quoted any negatively worded items so that higher scores indicated higher or better family health. You can go to the next. Okay. The short form is 10 items. And I think this is what most of you on here today will be most interested in, because this is what we're testing a clinical measurement from. And so the first 10 items begin with, in my family, we support each other, or we stay hopeful even in difficult times. And then there's 2 items that begin with in the past 12 months, if we had money at the end or adequate housing. These items were pulled from each of the 4 subdomains or dimensions. There's 2 to 3 questions from each of those dimensions. You can go to the next. And we found that the scale had strong psychometric properties. So when we looked at internal consistency, reliability, all of the subscales had Chrome box alphas above 0.8, as did the short form version. And sometimes the problem with Chrome box alphas is it's dependent upon the number of items in a scale. And so we wanted to also look at, well, what are the model fit characteristics through structural equation modeling? In our confirmatory factor analyses, all of them had good model fit. So we felt really good about the reliability. We felt good about the content and face validity. We also looked at some existing family measures, or we expected we'd have pretty high correlation there. And we found strong correlations with these validated scales, particularly with the family assessment device measuring family functioning and the family health climate score, which looks at a lot of these sort of healthy lifestyle factors. Next was when we took that short form, we wanted to see, well, can we establish some clinical cutoffs so that if at a doctor's office, or maybe it's at a Head Start office or some other social supports services that are available to families, that we could administer the short form of the family health scale and actually get kind of some cutoffs that give us some idea of how the family's doing and if maybe some referrals are needed. So what we did is, even though each of the items are measured on a 5-point Likert scale, we felt like we could dichotomize those items or make them into binary variables, looking at those who scored high on a 4 or 5 as achieving a 1 for that item, and then if they scored lower than that, is 0. So then we were able to sum the items for a score of 0 to 10, since it's a 10-item scale. We then had item cutoffs that if they had a score of less than 6, that was poor family health, 6 to 8 made for moderate family health, and 9 to 10 was excellent family health. We looked at our sample the initial sample of 1,050 adults and another sample that we had recruited of about 500 adults, and we combined the two because we had used the family health scale and the patient health questionnaire to measure depression in both. And so here with the PHQ, that's the patient health questionnaire, we looked at those who had moderate to severe depressive symptoms, and that's a score of 10 or higher on that scale. We can go to the next one. Next slide. What we found, and these are odds ratios, was that compared to families with poor family health, those who reported moderate family health had a 72% reduction in the odds of having moderate or severe depression. And those who had excellent family health as compared to poor family health had a 93% odds of moderate or severe depression. So that was kind of exciting to see. But those are really preliminary, and later Nomi is going to talk about some clinical studies she's doing to study clinical cutoffs further.
All right, I get to now transition us into some of the applications of the family health scale. As I do that, I wanted to say a quick hi, everyone. We have great colleagues and friends on this call, and exciting that you're joining us and connecting with us. So you'll be able to see that we have lots of stages of where we're at with applying this scale. So on the next slide, you'll see that one of them is a study that I want to talk about. So each of us will take a turn talking a little bit about what we've now done to apply this scale in the work that we're doing. So I just want to share, mine's one of the ones that's in the earliest stage. Some have more results. I am using this in my National Institutes of Health R01 study, which is called Family Matters. And that design is a prospective longitudinal cohort study. And our objective is to really examine risk and protective factors in the home environment for childhood obesity to reduce disparities. And this sample has 1,307 families with around 200 each from these different racial and ethnic groups. And I'm using this family health short form, and we'll be able to look over time for how this plays out in our families as far as risk and protective factors with child health and weight. So this study is, again, really starting ability to look longitudinally and having a chance to, in a large sample and a very diverse sample. And we have also translated it into languages of the different groups that are on this slide. So that's one example. You can go to the next slide.
Okay, I'll take this. This is actually from our initial sample of adults. We are interested in understanding what are the correlates of family health. Now we need longitudinal data to understand what predicts family health and what family health actually predicts itself. So we can only look at correlational relationships at this point, though we are working on, I'll talk about a longitudinal study in a bit. What we did find is adults who were experiencing moderate to severe depression, that was highly correlated with worse family health across all 4 dimensions. That's not really surprising. It's hard to say, is it because you have lower depression that you're reporting lower family health, or is it the less support and health of your own family that leads, exacerbates depressive symptoms? And it's likely a little bit of both. We also found that participants' executive functioning or self-regulation, that helped to improve family social and emotional health processes and family healthy lifestyle. Those from higher income households reported better family health across all 4 domains, though their education level was not associated with family health. Their subjective socioeconomic status, so how they felt they were doing in comparison to others, was associated with better family healthy lifestyle and more family external social supports. And then days of vigorous physical activity at the individual level, not surprisingly, was associated with better family healthy lifestyle. And those who are married tend to have a little bit better family health in some domains, though surprisingly, as we age, it might harm some aspects of our family health, but the household size and gender did not affect the report of family health. Another study that we looked at, do childhood experiences, particularly those adverse and positive childhood experiences, which often have a large family component to them, do they help individuals develop better family health as adults because of their household experiences? We know that adverse childhood experiences, or ACEs, lead to worse individual health, mental and physical, in adulthood. And some emerging research is showing that positive childhood experiences are even more influential on later health than adverse experiences, but in the positive direction. We can go to the next slide. What we found in this sample, we used structure equation modeling to look at these relationships. And we had participants who are on average 40 years of age, and slightly less than half were married, with about 3 people per household. And it was pretty evenly split between males and females. Go to the next slide here. What we found is that in each of these dimensions of family health, we looked at an unadjusted model where we only looked at ACEs and controls without the positive childhood experiences, and then just the positive childhood experiences. And then the adjusted model includes both the adverse and positive experiences in childhood. We found in unadjusted models that ACEs and PCEs on their own predicted each of the dimensions of family health in the expected direction. So ACEs were associated with worse family health later on, and PCEs with better. But when we combined them both in the model, what we found was that the effect of ACEs on later family health was reduced either a lot or was even not significant even anymore, though positive childhood experiences continued to promote better family health in adulthood. If I think about this sort of from a implications perspective, I want to say that the more we can do to promote positive childhood experiences, that in itself will help to reduce the trauma, but that is the most important thing to predicting later positive family experiences in adulthood. And another study that we looked into was 1 month into the COVID-19 pandemic. We did an internet survey on Amazon Mechanical Turk, where we applied the family stress theory to mental health. And we wanted to look at family health as a resource, and then sort of the meaning making that families had developed because of COVID. So there are positive things, like you felt like you're connecting more with your family due to being in the same, locked up in the same house with them. Or were you more annoyed with them, or was it a little bit of both? So let's go to the next slide. And what we found, this is a structural equation model. And for those of you not familiar with this type of method, you kind of read this like a map from left to right. So in this case, we looked at people's work or job loss due to COVID 1 month into the pandemic. And we found that it increased their more negative family meaning making, and it increased the negative, but it was also associated with less family health resources, not surprisingly. It wasn't significantly associated with the other aspects of family health. And then it's very strong that these family health resources were, if you had more family health resources, then that led to less anxiety and depression, versus if you perceived more negative meaning from the pandemic, then that increased your anxiety and depressive symptoms. And we found this even stronger a year later into the pandemic. I don't have those results here, but rates of anxiety and depression had doubled. About 50% of the adult population reported either moderate to severe anxiety and depression. And those family health resources were really important to those symptoms of anxiety and depression. And finally, we have a new study out where we're hoping that we get some longitudinal data from this study. It's called the Family Health Exploration Study. And in the past studies that we've reported on, we've only had one family member reporting their family health. For it to be a true family measure, we feel like we need multiple family members reporting. And so we've had both spouses or partners reporting. So a mother and a father who had a child between ages 3 and 13 at baseline. And so we wanted to also, we hope down the road in a couple of years to validate the scale among their adolescent children. And we hope we can examine some trends in family health over time and what are the predictors and outcomes of family health. This includes 500 couples around the US, and we'll have annual follow-ups. We just actually got the baseline data, and what I can tell you from our preliminary analyses is that males and females, or both partners, are tending to report very similar family health, which is encouraging to see that from a family as a family measure. So they're highly correlated. And so we hope to get those results out soon.
Okay, I'm up again to tell you a bit about my planned study. We're in the early stages of the study to examine the feasibility, acceptability, and utility of using the short version of the family health scale in pediatric settings. So we just won a grant from the Life Course Intervention Research Network, which is funded by HRSA for the next 12 months. And it's to look at how we can really use this in a clinical setting. So these are the aims of the study. It's to assess how feasible it is to implement this 10-item screener. Pediatricians have a lot of screeners that they administer to families. So how can we most painlessly integrate this screener into their practices, and then to examine both provider and caregiver, so parent perspectives or whoever's caring for this child, on the acceptability and use really of the screener. So are they able to use the clinical cutoff information that we've hypothesized from the validation work in the real world setting to make appropriate referrals, to, I think even before the referral phase, to really have conversations with families about what would be needed to better support the functioning of their family system. And then the third aim of this study is to validate the association of those clinical cutoffs with a range of both caregiver and child health and development outcomes, as well as their engagement in healthcare services, preventive interventions, as well as other services that are offered at the two clinics that we'll be piloting in. So the two clinics are urban clinics in Buffalo, New York, where I live. These are clinics that have a host of services available to them, both linked to the pediatric services as well as in-house. They're part of an early childhood comprehensive systems network, and they're just beginning the rollout of Healthy Steps, which is a 2-generation evidence-based pediatric intervention, really focuses on psychosocial screening, support, behavioral development of children, and we'll have interventionists embedded in the clinics as part of the Healthy Steps program. So the 10-item questionnaire will be just integrated into regular care of pediatrics of children 0 to 4 and their caregivers. We'll be administering the screeners in both English and Spanish, and then conducting focus groups with both pediatric staff and providers, as well as with caregivers, to ask them, is this in the realm of what you really want to be talking to your pediatrician about, and how best can we utilize information that we glean from learning a little bit more about how your whole family system works, in terms of setting you up with resources, both within the pediatric setting as well as in the community setting. So the idea is that our hypothesis is that screening for family health may provide a very efficient and low burden method to get at this holistic measure of family health, and really offer an opportunity for providers to communicate more directly about the importance of that family system working as effectively and in a nurturing way as possible, to support not only the individual child, but the family system that supports that child's growth and development over time. So we will keep you posted on the progress of that study. And now I think I'm kicking it back to Jerica.
Yeah, that would be me. So I'm going to continue our conversation about application and next steps. And so we have, you heard a lot of our work, and it's in many stages of developing and trying to create a literature for this scale for families and health, and to understand that construct better. So on the screen, you'll see we've had quite a few interested parties. So some of these are colleagues, some of these are people new to us who saw our study and were interested in trying to validate this in different cultures and languages. So currently studies that are either planned or ongoing are in these countries you see in front of you. And so we'll be able to build kind of an international literature using the Families in Health Scale. And several are including randomized control trials also, which will help us to really have a better understanding of some of these temporality issues that we always struggle with. Next slide, you'll be able to see that we, as a research group with the Families in Health Scale, have some other interests and next steps. And so we're continuing to refine the scale across cultures and languages. As more and more people are using this and translating it into their languages, it'll help us to continue to refine that scale. Also interested in adapting this scale for multiple ages and stages of life. So you heard Ali talk about multiple family members and helping to understand better the perspective of family health from the entire family system, that we think that's important, as well as being able to really adapt this for the different ages of family members and stages in which people live within the family cycle. So that is under works. And then really looking at trends in family health globally. As you saw, there's several people taking this work on as well, and it'll help to contribute to that larger understanding of family health globally. So we now want to spend some time thinking about clinical practice. So we are really interested in this, as well as all of you who've joined us today, I'm sure, who are connected with CFHA. That most of the audience really does have an interest in understanding not only in research and education, but the clinical application of this. And so we'd like to take some time to talk a little bit about, with the rest of you, about how this family health scale might work in the context in which you practice. And I know many of you cross those three areas of education, research, and clinic. Many of you do, and seeing how this might make sense to the work that you do. And my context, I have worked in family medicine for my whole career and have transversed across clinic, education, and research in different percent efforts across time, and realize that no matter what you create at a research level, it has to be able to be applicable on a clinical level. And so our hope is to be able to utilize, especially that short form, in a clinical setting as a type of screener. And we're hoping that it's broad enough to catch some of these other ones that you heard about, such as ACEs or food insecurity, or some of the other screeners that are individually being used, that this family health scale might be able to capture some of that, and it could maybe be utilized for that kind of catch-all and understand families' health in that more global sense, and help us to be able to screen and intervene with families rather than having to necessarily do 4 or 5 screenings at every visit. So wanted to set the stage for being able to talk through with some of you about some of these concerns that we know are very real in the clinical setting, such as feasibility, acceptability, and buy-in, some of the barriers that we would find, as well as opportunities, and then how you might see this working in your own settings for practice or research that you're involved in, or education. And thinking through that, if we do screen, of course, we don't want to screen and not have ability to provide resources or intervene. So what ways in which we might think about doing that, and what frameworks might work. And I think for most of us who are in these integrated care settings, we might have some ideas about that. So with that in mind, we'd like to turn some time now for some open conversation with the rest of you to learn a little bit more about some of your thoughts on this. And then time for questions and answers. And we would love to hear some of the questions we listed on that screen, but also anything that you might be thinking about as well. So I see one chat from Lisa. Hi, Lisa. Trying to find ways to encourage screening and family health in the effort of a well child exam for behavioral health. So yes, so settings in which behavioral health is integrated in primary care settings, how could this be utilized in well child visits or well child exams? I think that is one of the kind of primary ways in which I can see this being implemented. That's a place where there are lots of screenings, right? And so you have to think through, like, which are the ones that are going to take priority. And so would this screening be able to do some of what I was saying earlier, be able to screen for things that we normally now screen individually for, such as food insecurity, right? Or ACEs or things like that, that as you saw, this scale looks like there was correlations between many of those measures, and that it may be able to be used in that more broader global sense as one single screening that might help us to have those conversations in a well child visit. So other thoughts, Nomi or Ali, about that?
I'll jump in. I noticed an earlier comment about how PCs, or positive childhood experiences, are so hopeful, and I agree, and I would love to be able to screen for those, and you can to an extent, but it's hard to sometimes ask those questions of a young child. So you're asking it from a parent's perspective. And I think the short form of the family health, do we have a healthy family here, kind of gets at a little bit that ability of that family to provide positive childhood experiences for their children, if it's a family with children. And of course, it's applicable to families without children as well. But I think it kind of gives that positive perspective that we're hoping to see.
And I think just to add to the pediatric screening, I think it normalizes some of the topics that families might see as not in the purview of pediatrics, but very much impact day-to-day life of caregiving for a child, right? So family dynamics and communication and problem solving are all in there. And so to just sort of have a conversation opener with families, feel like they're able to reach out to pediatricians who tend to be, by and large, very trusted members of the team, to put those items on the table could really go a lot, could really have some impact. And I'm reading just a question here. I wonder why we decided to ask the question about trust in doctors as a negative statement instead of positive, since the other questions seem to be in the positive.
Do you want me to take that one, Nomi?
I took that one. I don't remember our decision-making process there.
So I can't remember with that specific item, but if you see the long form, it really is a combination of positively and negatively worded items. And kind of a best practice for survey research on these skills is that you have a combination of questions so that people just can't go through and just maybe get in the habit of marking one way, but it forces them to really read the question. So that was our thinking there, and that just happened to be one of the items that was more negatively worded. But again, it's a scale that's been around now for a year, and there's further refinement that I think will come to it and over time, and that may be one question we want to look at further. But right now, it's just more of we need questions worded in both directions to increase the reliability and validity.
Okay, I'll read a question from Janet. I have not seen the full measure yet, so apologies if this is obvious. I'm curious if the measure is able to differentiate helpful versus unhelpful support for healthy eating. For example, anxious focus on child food intake or weight can be perceived as supportive by parents, but in actuality, not effective or even harmful. I don't know if you wanted to take that one, Jerica.
I mean, you're definitely speaking to the issue of like unintended consequences, right? Parents always have the best intentions for their kiddos, but we sometimes do things that have unintended consequences, such as restricting food from kiddos or pressuring them to eat. And so it ends up in the long run to potentially lead towards the increased likelihood for overweight or obesity, or sometimes engaging in disordered eating behaviors. So we haven't, unless Allie has done this and I don't know yet, we haven't actually looked to see associations with that yet, because my study is one of the ones that we're just getting started with, to be able to look and see how that scale will play out in that realm with families and kids around feeding practices especially. So we don't know yet, but my thought would be that I think it probably will, because of the ways in which we have measured family health and in the way that we did. And we'll see, right? We're hoping to be able to see that. Have you had any, Allie, that I maybe don't know about yet to answer?
No. So I agree with you, Jerica. I will say the dimension on family healthy lifestyle, it's looking at healthy lifestyle pretty broadly.
Yeah.
So that scale in and of itself won't get into all the dimensions of healthy eating. There are some skills that are specific to that. This is sort of a broader measure of family health that way.
Yep.
Haven't looked in depth yet.
Yep.
Great, thanks.
We have another question from Barbara. This is very exciting. I can see broad applications in pediatric primary care, particularly in settings that have integrated behavioral health care. I'm thinking about use with families with a child with chronic disease. Could facilitate broadening intervention considerations and thereby improve the trajectory of chronic disease management. I think absolutely. Chronic disease is one of those areas that would really, I think, benefit from that longitudinal assessment, over time, seeing how the family system is integrating management and adherence to, a potentially stressful, stressful and long-term issue. So I absolutely think it's a great hypothesis.
So one of the things I think we selfishly are hoping to hear from some of you, because we know you are integrated behavioral healthcare providers, or some of you are physicians in integrated settings, or work in ways in which this makes sense, or you would understand clinically how there could be some barriers or buy-in issues. So I would just love pretty blunt feedback about how you react when you hear us talk about a family health scale, and when I was suggesting like it could take the place of some other screenings, and that's sometimes hard to convince people of, right? Because we're used to doing certain screenings, and you have to feel really convinced if you take one away that this one would be better, or serve a purpose that could be a broader, better purpose. And just changing people's practices, all those things are really tough when you kind of in the day-to-day world of clinical practice. So would love to just hear kind of your initial reactions, because that really helps us. We're not looking for social desirable responses here. It really is like, what is your reaction? What do you think about this in a clinical setting that we're going to be needing to really think about as we move forward in some of our efforts to try to integrate this even more so in clinical practice?
Can we just speak, or would you prefer the chat?
No, please go ahead and speak.
Okay, hi, this is Janet. Sorry, I'm not on camera, but this is Janet Lake T from Illinois. I thought your plan of having an interventionist in the clinic as part of one of the grants you mentioned was brilliant, because my experience is that if there is somebody to do it who's already trained, that it's much more than PCPs are happy to utilize the information, but adding one more thing to their very limited time can be very burdensome. So I think getting integrated care behavioral health providers into pediatric settings is really important. And I have a BWET grant, 2 of them now, and it's hard. If they don't already have one, it's a hard setting to break into. So I thought that was great to include it. And I just am always looking for how do we, help prove the utility of adding a behavioral health provider in pediatric settings so that they can do this kind of work, which truly will benefit patients and families, I'm sure.
Thank you for that comment. Yeah, so for this pilot grant, it was really, we're taking advantage of the serendipity that the Healthy Steps model is being rolled out at the same time that this grant, the feasibility grant, is being rolled out. So there will be trained early childhood interventionists that will be trained in behavioral health and pediatrics. And the idea is if we can show that screening for family health and focusing on those lower level scores can help optimize some of those services, improve engagement. So I think the fact that we have settings that already have a ton of integrated resources is probably the first place to start to make that argument, and then hopefully advocate for other locations that might not have those resources, to go for them as well.
Mm-hmm. I mean, this brings up the question about who does the screening, right, in clinics, and it does vary a lot. I think, Janet, your point about having someone who is embedded to do this type of work really helps, but it's true on a day-to-day basis. I mean, a lot of us have MAs who do this, or nurses who do the screening. Sometimes the docs will do it depending on which screener it is. There's different processes and protocols in behavioral health clinicians, depending if they go in at the beginning of a visit, or if it's a warm handoff, or if they're seeing someone separately. I mean, there's lots of different ways this could be implemented, and each of them have some opportunities and some barriers to them. But I do think that there is lots of opportunity for figuring out how to build this in as a screener. Another one that I think probably a lot of you are probably using in your models of care are community health workers. And that's in Minnesota become a very strong focus of the work that we're doing. And so one of the studies right now that is an RCT that's just recently funded will be utilizing community health workers. And part of what we're planning on doing is having them do this family health scale as part of the package kind of that they bring to the work they'll do with families. But I wondered, when you think about that, it's hard to keep track of like who's doing which screening in the clinic and how they all stay. And it relates to the comment that Barbara mentioned about making sure this is electronic, whether it's through tablets or other ways to kind of track and make sure these get into patients' charts or being able to make it a little more feasible. I agree, but I was going to ask you if you could comment, did you mean even like sitting in the waiting room or more so like interactive in the actual visit when a family gets brought back? Because another place that screenings happen often too are in the lobby or the waiting room before they get pulled back to their visit. And if you think there's pros and cons or reasons to integrate this in such a way, like, because sometimes things are more sensitive and you want, you do them in a certain place on purpose because of that.
Right. Well, this is Barbara. I have worked in pediatric primary care. I'm not working in that setting at the moment. But a lot of I do a lot of training in pediatrics across the state of Connecticut. And a lot of our offices do their screening in the waiting room. Yep. And if the screen is not completed, then the MA or nurse bringing the family into the examining room can also encourage that. And for some families, if it doesn't get done, then doing it, so I think it's not a one size fits all. You need to have that model of what typically happens and then make adjustments when it can't quite happen that way. But more and more, the questions that you're asking, pediatricians really do ask a lot of these questions, but they're just not formalized, sometimes don't get reported consistently. And the emphasis now on outcomes, and more scrutiny of all medical outcome data will bode well, I think, for using a measure like yours and being able to document and expand what you're addressing, because we know these things impact health outcomes. That's the whole bottom line issue. So when you're making the case, of course, to the primary care folks, that's the bottom line, right? That they need, So I'm thrilled about your measure, and I will connect with you again, hopefully, because I could really, we're working on some, consulting with the Connecticut Children's Medical Center that now has over 20 pediatric practices that are connected with them, and will be embedding behavioral health providers. Hopefully, it won't be all immediately, but over time into these practices and training them. So to start, I'm going to see if we can maybe start to use this tool with some of the practices. We'll see what happens. But anyway, so thank you very much for doing this work. This is great.
Yeah, thank you for your comments. And yes, please email us and we'll send you all the things that you might need to consider using this. You mentioned something I think that's really key is the buy-in, right? So it's hard, when you have to decide how you're going to spend families' time in the lobby, in the waiting room, or in the actual exam room. There is, lots of questions about which screeners take priority, and you have to be able to convince, the practice group or whoever has the power that the screener is the one that should be chosen or put together with a larger battery of screening. And so I think your points are well taken, that the more you can show that this is connected to outcomes, that is convincing. So thank you for those comments.
One thing that this reminded me as well is, billing barriers. So I'd love thoughts if folks have creatively used billing to discuss family level issues that go beyond the health of the individual child, for example. I think having a systematic way to assess that, yes, these questions have been asked and then also addressed, could be a way to, get those family level codes in there and get reimbursement for providers' time. And yes, we will be sending, I think the PowerPoint gets sent out, so we'll include our contact information as well, so that'd be wonderful. So yeah, I had just sort of an open-ended question about billing and kind of reimbursement because of course, this is going to take more time and effort. It might be the time and effort that pediatricians are already spending, but to then actually be able to document and then get reimbursed would be important.
So I assume that many people don't maybe know like how that works, or they also have the same question. So I was going to actually ask you, Nomi, what are they planning on doing in your pilot study? Is that just going to be outside and not deal with that aspect of it at this point?
So it's going to be under the umbrella of the Healthy Steps program. And they're already, so there is, again, the program is getting set up this month. It's sort of being rolled out this month and over the next couple months in the practices. So there will be a battery of screeners, in addition to the family health screener. They also, they use the We Care screener, which asks about more material needs, and whether or not, and some ACEs type questions, and whether, importantly, I think for that screener, it's also a 10-item screener. They ask the families, would you like this issue addressed today at your visit? So for each of those items. And so there is a discrepancy, and this is why I think the focus groups will be really telling with the parents. There is a discrepancy between, you know, what families list as challenges that they're experiencing and the items that they actually want to discuss within the context of the visit. So I think qualitative work is really necessary at this stage of things to both think about, you know, the extent to which the questions do resonate with parents, and then also ask them how they would prefer, how it would be most beneficial to them to have these conversations occur, and what types of resources they would be open to participating in, right? So you don't want to give them a bunch of referrals and then they don't show up to them. So right now it will all be integrated within this Healthy Step model, which includes interventionists and a larger battery of screening.
I guess I'll just say, first of all, thank you for coming in. There are many friends and colleagues on this call that I admire and so much in what you do in your research and clinical work. So thank you for taking the time to listen. Also really invested in if others want to connect to this work, that we're very, very collaborative and open to being willing to share this work and for you to join us in this work. So thank you.